Okay, so yeah, I'll be talking about registry data as a rare data disease resource. So this is something that I've looked at in my PhD studying rare disease natural history modelling. So as we've heard in some of these talks before, and I'm sure most of us are aware, rare disease data sets are very scarce. When we do get them, then they tend to be quite small. And as a result of these things, they can be quite heterogeneous. So if we're combining different types of data or from different study periods to try and get as much of a picture of a disease as possible, then it may not be appropriate to combine these without accounting for the heterogeneity that is there. So I've been looking at rare diseases in the context of natural history modelling, where we map out a typical disease trajectory for a particular disease. And these are useful for subsequent treatment analyses. If we can develop a treatment that's targeted at any stage of the disease or the whole disease, then we can compare that to the natural history model to see if this is a more effective and a more clinically effective alternative to the current standard of care. So the main research question that I have been looking at is how to appropriately combine all the available evidence that we've got into a rare disease natural history model. So we may have a lot of different data sets that we're trying to combine. Ideally, we'd want to be looking at 1 or 2 big cohort studies or perhaps control arms of clinical trials, because these are very good for representing standards of care. But it's unlikely that we get these in a rare disease, particularly over the whole lifetime of patients. So perhaps we have to combine that with some test data or some registry data, or even elicit some opinion from clinicians or healthcare experts to fill the gaps in models. So this was something that I looked at in a thorough simulation study to try and assess how appropriately we can model all these things together. But one particular area of interest that I encountered was whether or not we can get all of the data we might need from registry data sets, which collect long-term follow-up, and it would be possibly preferable if we can just collect all of our data from one source, because then we don't need to worry about accounting for any heterogeneity if it represents that population that we're looking at. So to try and answer that question, I looked at the CPRD, the Clinical Practice Research Data Link, which, because I'm short of time, I won't go too much into. I'm sure we're all fairly familiar with it, but it's a UK-based electronic health record with GP data that we can link to other data sets. In my analysis, I looked at linking it to HES data and to ONS mortality data. And the case study that I looked at was a rare disease called Duchenne muscular dystrophy, which is a rare muscle wasting disease with a global prevalence of around 1 in 3,500 live male births. There's currently not a cure for this disease, and the intermediate events that I was looking at to map out the natural history of Duchenne were steroid use, spinal surgery, ventilation, and cardiomyopathy. And then a key part of natural history modelling is accounting for mortality at all stages of the disease, so that you don't introduce bias with inflated estimates of lengths of stay in earlier disease states. So I extracted those 4 intermediate events and the terminal mortality event from a collection of CPRD records and HES records. So steroid use, I defined with clinical supports, product code lists for oral corticosteroids. And I wanted to look at temporal use of steroids, but I wasn't able to do that because of the poor quality of the data in the CPRD for steroid use. It was unclear if there were gaps in patients taking steroids because of moving in and out of practices, or if that did truly reflect their clinical profile. So instead, I just took their first steroid use as the event of interest. Spinal surgery and ventilation, I looked at the HES records to identify the first instance of those events. And cardiomyopathy, I used code lists in CPRD and did inspect ONS records for secondary analyses, but that had some problems as well. So I stuck with the code list that I developed, and mortality was fairly well recorded in ONS records. And if it was missing from those, there were a few instances of supplementing that with CPRD recorded mortality. So in terms of reproducing mortality compared to what we've observed in the literature, that was really well reproduced. So on the left-hand side, we've got a plot of survival of the CPRD cohorts compared to a global population identified from a previous literature review that I did. So the red line of the CPRD probabilities really overlaps quite well with the yellow line of the literature probabilities, and that's, as you'd expect, then reflected in the mortality rates on the right-hand side. So there's the bottom line is the non-Duchenne population, so very negligible mortality up to age 50, and then the increased mortality in Duchenne patients that had been observed in the literature, particularly from ages 10 to 40, was reflected in the CPRD population. However, when I went to these intermediate events, then the prevalences of these events were much lower than what we might expect. So, for example, first corticosteroid use was recorded in just under half of the patients, when in fact we'd expect around 90% of patients to take steroids. And similarly with the other events, spinal surgery, ventilation and cardiomyopathy, there were much lower prevalences observed than we would clinically expect to happen. In the subset of patients that were observed to have all of these events, then the mean immediate onset times of those events were a bit more consistent with clinical records, but yeah, the prevalences were much lower than we might expect. So that suggests a limitation of the CPRD for rare disease natural history modelling. So just to sum all that up, I think the main finding was the validity of the intermediate events was probably questionable, and that was because we don't observe patients across their lifetime in the CPRD. We only observe them as they move in and out of CPRD recording practices. So it was tricky to accurately reflect the proportions of patients that experience those intermediate events. But the mortality data and estimating age-specific mortality rates was really well reproduced in the CPRD. So I think that's a potentially very powerful tool moving forward for rare disease natural history modelling, because mortality rates are so key to that. So if a lack of mortality data is affecting your rare disease analysis, which it may well do if you've got limited follow-up, then electronic health records such as the CPRD may offer a really good solution. Then there's questions and marks around generalizability. If the CPRD is representative of all UK patients in this case, I guess it wasn't for these intermediate events, but it's important if you are considering using electronic health records to make sure that it's going to represent a population that you're interested in, and it's going to be similar in population to the other data sets you might be combining it with. Otherwise, you may need to consider accounting for that in your model. And then going forward, I guess if you can build these models using these electronic health records, then it's good to be clear with your methods of how you've done that to enable reproducibility, so that you can update that model over time with newer patient cohorts. So there's just a few selected references. Hopefully that was a brief enough whistle-stop tour, and if you've got any questions, I'm happy to answer those in the chat function or the Q&A function.